Medical coding relies on precision, but one specific scenario consistently trips up even experienced coders. You look at a patient's chart, you see a list of symptoms, and you have to make a choice. Do you code those symptoms individually, or do you wait for a final diagnosis? Make the wrong choice, and the claim gets rejected instantly. To solve this, the ICD-10-CM manual provides a strict structural blueprint, guideline IB.4. The tension here is deciding whether a symptom, like a cough or a fever, stands entirely on its own in the medical record, or if it is merely a fragment of a larger, unified disease process. Resolving this tension is not a matter of clinical guessing. It requires following a strict logical algorithm, one that is driven entirely by the confirmation status of the provider's documentation. Mastering this specific logic gate is the only way to separate compliant, fully payable charts from inevitable, costly denials. Before we trace the logic of guideline IB4, we have to define your boundaries as a coder. The golden rule is that the explicit written documentation provided by the clinician is your absolute constraint. The most common professional error you can make is assuming or inferring a diagnosis from clinical clues. If the provider has not explicitly confirmed a condition in writing, it does not exist for coding purposes. Crossing that line and assuming a diagnosis leads directly to severe compliance failures and immediate financial denials. On the flip side, coders often commit the inverse error, leaving a chart blank by failing to assign codes for documented symptoms when no overriding diagnosis is established. Under guideline IB4, your function is strict textual translation. You are translating exactly what is written, without applying independent clinical deduction. This animated diagram represents the IB4 decision tree. We will use this as our mental model to process how symptoms should be coded. We start by feeding raw, undefined symptoms, like pain, fever, or a cough, into the top input box of our decision system. Those symptoms immediately drop into our first logic gate, asking the foundational question, is a definitive diagnosis confirmed by the provider? Let's follow the negative pathway first. This simulates a chart where the provider has noted the symptoms but left the final condition unconfirmed. The rule here is absolute. When the definitive diagnosis is not established, you must assign the corresponding symptom code. To find these codes, you will primarily look in Chapter 18 of the ICD-10-CM manual, covering codes R00.0 through R99. This section acts as the main repository for unconfirmed signs, symptoms, and abnormal clinical and laboratory findings. So, when the clinical picture remains incomplete, coding the documented symptom is the only compliant action available to you. Many beginners assume that if they are looking for a symptom code, they will automatically find it by flipping straight to Chapter 18. While Chapter 18 is the primary home for these conditions, this diagram shows how specific symptom codes are actually distributed throughout the entire ICD-10-CM manual, categorized by their corresponding body systems. Because of this distribution, you must rely on the systemic if-then logic of guideline IB4 to govern your coding choices, regardless of where the code physically lives in the book. In symptom coding, the overarching systemic rules always override a code's geographic location. Now, let's return to the top of our decision tree and explore the alternate reality, a chart where the provider actually establishes a confirmed diagnosis. That yes triggers a secondary logic gate, which asks, is the symptom integral to the confirmed condition? An integral symptom is a standard, expected, or inherent component of the disease process itself. For example, joint pain is an integral symptom of arthritis. If we follow the affirmative path of this second gate, we are dealing with a documented symptom that is a known, expected part of that confirmed diagnosis. The absolute rule for this scenario is clear. Do not code the symptom separately. The core concept here is that the diagnosis replaces the symptoms. The final diagnosis code inherently includes and absorbs the integral symptom code within its definition. Coding an integral symptom alongside its parent diagnosis constitutes overcoding. This is a direct violation of guideline IB4 and frequently triggers claim rejections. A definitive diagnosis acts as a heavy anchor, pulling all expected integral symptoms into a single, unified code. To recall this algorithm quickly during live charting, we use a reliable mnemonic device called the AMCI MJ-GEM. It states, no diagnosis, code the symptom. The first half of the mnemonic reminds you that if a confirmed condition is absent, you must capture the clinical reality exactly as written by coding the symptom itself. The implied second half reminds you of the inverse. If a confirmed condition is present, the diagnosis replaces the symptoms, and any integral symptoms are dropped from your code list. Committing this simple two-part phrase to memory perfectly replicates the results of the complex logic tree we just built, ensuring your coding remains consistently compliant. Let's review this completely illuminated diagram of the B.4 decision tree, showing all inputs, gates, and terminal rules working as a unified system. It hinges on the single most important question you must ask yourself: do I have a confirmed diagnosis or only symptoms? Rigorously applying this question eliminates coding errors, ensures accurate clinical representation, and prevents automated claim denials. Strict adherence to explicit documentation and algorithmic logic is the definitive way to master symptom coding and code the AMCI way.